Hypertension Awareness Series Episode 22. Good morning. Today we learn about BP treatment targets. How low should you go? And the answer is simple. As low as reasonably achievable. The new principle. So the key thing is the lower the better, but this should be done safely. The goal is to reduce cardiovascular risk, but also avoid harm, hypotension, syncope, and renal injury. Why do targets matter? Treating hypertension significantly reduces cardiovascular risk. Stroke is reduced by 35 to 40%. Heart failure is reduced by 40 to 50%. You reduce heart attacks and myocardial infarction by 20 to 25%. And the overall cardiovascular mortality is reduced by 20 to 30%. So even a 10 millimeter decrease of systolic BP causes major benefit. But too low a BP can cause danger, orthostatic hypotension. So what are the targets for most patients? I'll look at the various guidelines. From the ESC guidelines, targets of systolic BP of 120 to 129 and diastolic BP of less than 80. Avoid going too low. The new principle is Alara, as low as reasonably achievable. The AHA guidelines, the target is less than 130/80 for most patients. For the Kenyan guidelines, target less than 140/90, but high-risk patients less than 130/80. What are the targets in special groups? For the very high-risk patients, patients with CKD, cardiovascular disease, most guidelines agree a target of less than 130/80 for high-risk patients. For the elderly patients, for the frail elderly, individualize the targets as low as reasonably achievable. So your targets can be below 140/90, 150/90. Watch out for orthostatic hypotension in the elderly. The danger signs to watch out for is dizziness, falls, rising creatinine, reassess and adjust therapy. There is what we call the J-curve concept. The cardiovascular risk decreases as the BP decreases, but going too low can increase the risk, especially in patients with coronary artery disease and elderly patients. Do not go too low. So what is the practical approach for targets? Step 1, get the blood pressure to below 140/90. That should be your primary goal. Then you can go lower as tolerated. If possible, below 130/80. For your high-risk patients, targets should be below 130/80. Don't go too low because you have said going too low can cause more harm. Avoid over-aggressive lowering. At every step, monitoring is key. Let the patient monitor the BPs at home. Empower them. Let them have a BP diary, home BP monitoring, so that you avoid the issue of the white coat effect when the pressure is high in the clinic. So monitor the BP at home. Monitor for orthostatics. So you are monitoring the BP when the patient is seated or supine and standing. So you're able to pick orthostatic hypotension early. So for treating to target, go as low as reasonably achievable. Your primary target is BP below 140/90, and then you can go lower as tolerated, if possible below 130/80, and especially in the high risk patients. Good control of the blood pressure, you are able to prevent the complications. So let's not be comfortable. The patients keep coming to the clinic, BPs are 155/95, and you continue the same treatment, therapeutic inertia. Treat to target as low as reasonably achievable, avoiding the side effects or the complications of hypotension and dizziness. So in summary, the treatment targets, the key principle, as low as reasonably achievable. Low to prevent risk and also prevent harm. Primary target, BP below 140/90, and then go lower as tolerated below 130/80, and if possible even 120/80. Don't go too low because too low can cause harm. Home BP monitoring is key. Watch out for the side effects and for symptoms of orthostatic hypotension. Treat to target as low as reasonably achievable. Do not miss our next very important episode where we discuss about hypertensive urgencies and hypertensive emergencies when very high BP becomes life-threatening. As always, Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.